So yeah guys, welcome to part 2. So one of the things, one of the common infections that I forgot to mention here is your diabetic foot ulcers. Those ones, they do get septic, um, and when they do, they need to be amputated. They need to be amputated because as long as the source of infection is there, the patient will get into septic shock and eventually pass away. So they're usually done as an emergency when the patient comes in. Okay, so let me do this. So what I want us to understand, guys, here is that when you've got an infection, like we said, an infection, not all infections will lead into bacteremia. And not all infections will lead into sepsis and progress to okay, let me say severe sepsis and septic shock. And then once you get there, you've got a chance of getting into multi-organ dysfunction and then death. Okay, so we listed the infections, the most common sources here, which are pneumonia, diabetic foot, abscess, septic, post-operative wounds, things like that. Not all of them. Yes, there might be infections, but they are still localized. They are just infections. Not all of them. Not all infections, like I said, will progress into bacteremia, into sepsis, into severe sepsis. So we said if you've got a patient who's got a localized infection, as long as they have normal vitals, we are happy. As long as they've got normal vitals, we are happy. As long as they are clinically stable, they're not ill looking, they don't look toxic, we are happy. And remember, okay, and then once you get once now you've got a patient now who starts to have, like we said, an increased pulse, which is tachycardia, they start to have reduced BP, a hypotension, they start to have a high lactate, increased white cell, a high temperature, then that patient has got sepsis. That patient has got sepsis. Once on top of all of these, you have organ dysfunction, some organ dysfunction. Then that's severe sepsis. What is organ dysfunction? When you think about the kidneys, think about oliguria. So a patient who fails to, remember, a normal urine output should be 0.5 mils per kg, between 0.5 mils and 1 mil per kg per hour. So if that doesn't happen over 2 hours, then the patient, especially if enough fluids have been given, give them enough fluids, but they are still oligouric, they are still anuric. Then we do the bloods, they've got the high creatinine, they've got the high urea. That patient has got an organ dysfunction, which is renal in this case. In terms of the lungs, once they start to be tachypneic, they're dropping sets, they've got that's the reduced partial pressures of oxygen, they are not maintaining sets, it means now the respiratory is involved. In terms of the liver, once they start to have an increased total bili alone is okay. The minute you get into deranged transaminases, all those things, it's severe. In terms of the hematology, so which means when you have a patient who's got sepsis, these are the bloods that you're gonna have to do so that you can grade their sepsis. Are they having severe sepsis? Are they having just sepsis or severe sepsis? Because by definition, severe sepsis, there must be evidence of organ dysfunction, not multiple organs. Just one is enough. In terms of the hematology, a drop in platelets, and then now one of the things, you start having your INR being deranged as well. In terms of the brain, a low GCS, which is reduced level of consciousness, they might start to have other things as well. They might just be restless, things like that. So these are our major organs. I'm not sure if I'm forgetting any organ now, but these are the major ones. These are the major ones. Let's talk a bit about how do we get here. So you've got a pathogen. You have a pathogen in the form of a bacteria, a virus, a fungi. Fungi are not common causes of sepsis, especially in the immunocompetent, but they are very opportunistic. Once a patient has got decreased immunity, they start to have a pattern. The common ones are your bacteria, and bacteria are very, very common, both the gram-positive and the gram-negatives. But viruses are also a cause as well, because now you've got COVID, you've got the rhinovirus, you've got adenovirus, syncytial viruses, and there are so many, even hemophilus. So now you've got a pathogen. The pathogen itself is not the main, it initiates, but it's not the main reason why we get systemic inflammation or a systemic infection. The pathogen itself, it causes the immune system to respond, and the reason why we get into all of this is because the immune system triggers a response and it starts having an increase in your cytokines, leukotrienes, and other inflammatory mediators. And this is how Yes, there are bacteria that do secrete toxins, which those toxins they do cause vasodilation and also induce more inflammatory reaction. So basically, sepsis is more of an inflammatory response by the body. That's why we get there. So the cytokines, the leukotrienes, and other inflammatory mediators and the toxins of the bacteria are the ones that causes all of this. Yeah. So the reason why we get an increased temperature is because of, if you remember the how a temperature increases, it's not really because of the bacteria itself, but it's because of the inflammatory mediators that are being formed and secreted in huge amounts in the presence of an infection, right? And remember what we said. We said that, I mean, the issue of tachycardia, once you've got high temperatures, once you've got pain, once you've got infection, tachycardia is going to come. There are instances where tachycardia is the only abnormal vital. But once you've got a tachycardia plus a temperature, and remember what we said, a tachycardia that is worth noting, it depends where you are. In OPD, a tachycardia that's going to make me to jump and say what's happening is the one that is more than 115. But anything above 100 in ICU should make you to want to look what is happening, right? And we did speak about lactate. Lactate is a very good marker for hypoperfusion. So once you've got hypoperfusion, then the body starts to switch from aerobic respiration to anaerobic respiration. That's how you produce the lactate. And the normal high lactate should be about 1 point something. So once it's above 2 millimoles per liter, then that's a high lactate. And lactate is one of the things that responds when you start managing the patient. Once they start getting enough fluids, then they start to respond, right? Let's talk about septic shock. So I'm going to repeat. Infection is just a localized inflammatory and infective process. It's localized. Nothing is in the blood. It's just localized. Nothing to worry about. But it can get into the blood depending where the infection is. Like for instance, a localized infection in the face should worry you because it's very close to the brain. It's very close to the heart as well. But an infection in the leg, in the hand, in the arms, so it depends the location of the infection and the chances. What are the chances that it will actually become the bacteria is going to get into the blood? What are the chances? But the closer it is to the heart, the closer it is. If it's in the face, it's in the scalp, be worried. It's very close to the heart. It's very close to the brain. So it's like a kid with otitis media. Be worried. Yeah. So infection localized. You get there. This can be symptomatic or asymptomatic. But once now you start having a systemic signs of infection, these are the guys that are going to tell you that, look, you are dealing with a systemic infection now, not just a localized infection. So once you have got these, make sure that you rule out some organ dysfunction by taking bloods, take your ABG, and all of that. And then now, with shock, what is shock? A septic shock is shock that does not respond to fluids, to IV fluids. When you've got hypovolemic shock does respond to fluids. And anaphylactic shock does respond to fluids a bit, but you need epinephrine there to get the patient out of anaphylaxis. So what I'm trying to say, if you get to a point whereby you have given a lot of fluids, you cannot be giving 3 liters of fluids or 2 liters of fluids, but the patient is still in shock. It means that as much as you are correcting the hypo, you are giving more fluids. If it was hypovolemic shock, the fluids should be able to take care because you are giving fluids. But if the shock is not due to hypovolemia, your fluids, no matter how much fluids you give, the patient will not get out of shock. So that's one sign that you can give a lot of IV fluids, but if it's septic shock, it's not gonna respond. And which means now, in order for this patient to respond, you need vasopressors, Dobutrex, dobutamine. So basically, what I'm trying to say is a shock that doesn't respond to IV fluids, think about septic shock. A shock that needs vasopressors, think about septic shock. Right? And then now, this guy is all about what we spoke about earlier on, the multi-organ. Once you have what one of these organs, I mean, this is a multi-organ failure, so it means for you to say it's multi-organ failure, they must be greater than 1. Must be greater than 1, not 1 or equals to 1. Must be greater than 1 to say it's multi-organ. So when you've got 2, you've got 3, you've got 4. As long as you've got more than 1, that's a multi-organ dysfunction. But as long as you still have 1, you just have severe sepsis, right? Just have severe sepsis. But now we're already talking about ICU here. We're already talking about ICU here. So this is sepsis, guys. I'm not sure if I'm leaving anything. So what the point that a very big take-home message here is that once you've got a patient who's got some kind of infection, they come to OPD or wherever they've got some kind of infection, yours is to look at the vital signs. Look how the patient is clinically. Do they look toxic? Do they look sick? And then look at the vital signs. Once you've got abnormalities there, even if the vital signs are still normal but the patient appears ill, you rather want to investigate that patient and keep them for IV antibiotics, because the only way to get out of this is to give the vasopressors, if they are here, give enough fluids and give antibiotics and support them, because some of them might even come in when they've got some respiratory compromise. They might even need intubation. That's how bad sepsis is. They might already be having how come I didn't put the heart here? The heart is supposed to be here. So you have a reduced cardiac output there, a reduced blood pressure, the hypotension, you've got a tachycardia, then you might even end up having cardiogenic shock. So now you've got 2 types of shock. It's not impossible to have 2 types of shock in one patient, or even more than 2. So the index of suspicion in this kind of patients is the only thing that's going to help you out. So when you've got an infection, make sure that the vitals are fine, the patient does not look ill, if you can say that they can go home. So I don't want to make a separate video for investigations, but the investigations you can already see. So you are going to do your history, physical examination, and try to locate the source of infection. Once you have done that, there are things that you can do there and there, like as in, depending how the patient is. If the patient already comes in, you are in casualties, the patient has a loss of consciousness, they have been vomiting, they've got low sets, obviously your CAP takes priority, circulation, airway and breathing. So it takes priority. Remember, for trauma is ABC, but for medical emergencies is called a CAP, circulation, airway and breathing. And for circulation, airway and breathing, So it means you're gonna take care of the circulation first, meaning the lines, all of that, and give them oxygen, and make sure that they, if you need intubate, you intubate, so things like that. So the investigations is basically, yes, you're gonna do your FBC, do your UNE, do your LFT, because you're trying to screen for this. So that's why I say I don't need to make a separate video, because I've already said that to check if the patient's got anuria or oliguria, the only thing to do there, the only way to check is to put them inside a catheter. In any case, when you are doing resus, a patient needs to have a catheter. In any resus, patient will have a catheter. And then you just take note of the time when you inserted the catheter and give the fluids, and then monitor your fluids, how much I have you given. And after 1 hour, after 2 hours, you should know and go and check your bag if there's anything there. Because if you have given a lot of fluids but the patient is still not passing urine, that patient is anuric. And then your bloods will tell you if you've got high creatinine or high urea. And then you do ABG, which can tell you that you may be having some kind of a disorder, acid-based disorder there, and drop in sets, partial pressures, and all of that. Do LFTs, check for Bailey and your other liver enzymes. You do your FBC is gonna tell you about the platelets. Because remember, with DIC you get low platelets, and your patient can get into DIC when they've got a severe infection, bacterial infection, and then there isn't much that you can do for this thing, for the brain. Then for the heart, it's just to check the vitals, what's happening. I cannot think of any. You don't need the chest X-ray here. You don't even need an ECG, not unless there's another indication for it. But as far as I know, so your immediate is your ABG. ABG is gonna tell you a lot of things. If you've got a patient who's got sepsis, they've got a lactate of like 4, 5, 6, then you know, and that patient definitely will have acid-base disorder, because lactate on its own causes acidosis. And yeah, guys, I hope I've done justice to this topic. So in terms of the management, like we said, fluids, give antibiotics, and don't forget a blood culture, because you want to know what kind of a bacteria are you dealing with there, because you're gonna start with broad spectrum antibiotics, and then after getting the results, then you can now sort of like try to de-escalate and use the appropriate antibiotics, which are narrow spectrum. Because once you get the results, you're gonna go narrow spectrum now, and like targeting the specific bacteria. Yeah, guys, thank you.